And the link to this recording can be found on that website, speakers.roseman.edu. So you're welcome to share that recording with anyone that you'd like. We'd like you to put your questions in the chat function at the bottom of the screen, and we'll stop at various times to be able to address some of those questions. With that, I'm extremely proud to bring to you with Dr. Cheryl Brewster this important topic tonight: diversity, equity, inclusion in the health professions. I'm very proud to introduce Dr. Cheryl Brewster, Senior Executive Dean for Diversity, Equity, and Inclusion. Dr. Brewster joined the Senior Executive Leadership Team at Roseman's College of Medicine in 2020, and she will lead the development and implementation of a proactive diversity, equity, and inclusion initiative in support of the college's strategic plan to create a learning and working environment where all have an opportunity to succeed. In her role, Dr. Brewster will actively engage students, faculty, and staff to further behaviors, attitudes, and policies that support diversity, equity, and inclusion. Prior to Roseman, Dr. Brewster served as Associate Dean for Diversity and Inclusion and Associate Professor at Florida International University's Herbert Wertheim College of Medicine. During her tenure of 10 years, she provided guidance to the Dean on enhancing the culture of the college and developed and managed a comprehensive diversity plan inclusive of goals, policies, and practices for administrators, faculty, staff, and students. She was actively involved in all diversity, equity, inclusion activities, including the hiring practices of faculty and senior administrators. She served as a voting member of the Student Admissions Committee, and she developed and facilitated numerous workshops for the college. Dr. Brewster implemented pipeline programs in partnership with minority-serving undergraduate institutions and received funding, $2.1 million, to implement programs and form additional partnerships with HBCUs. Dr. Brewster was elected into a voluntary leadership role with the AAMC to contribute to the issue of diversity at all levels in academic medicine, serving a 2-year term with the group on diversity and inclusion. In 2017, Dr. Brewster won the Presidential Award on Diversity. Prior to arrival at FIU, Dr. Brewster was the Associate Director for Research at the University of Miami Miller School of Medicine, working on a myriad of chronic disease prevention projects for almost 3 years. Dr. Brewster's training is in community-based public health, and she has over 15 years of teaching health education public health courses. She spent 1 year in London to complete coursework at the University of East London in the Gender, Sexualities, and Ethnic Studies program, examining the interface and intersection of social divisions. Dr. Brewster remains committed to serving her community in various capacities and serves on numerous boards. Please join me in welcoming Dr. Cheryl Brewster.
Thank you very much, Vanessa. Sometimes I forget things that I've done. I was like, oh yeah, I did do that. So thank you for the refreshing reminder. So yes, I would like to welcome everyone to this talk tonight. I think it's a really timely talk. I think it's an important talk to discuss diversity, equity, inclusion within the health professions, and also looking at health disparities and also how we can solve some of the problems that are existing. Here we go. It's advancing now. So riddle me this. I thought I'd open up with a little levity and just relax everyone, have no tensions. I know it's been a rough day from work or school. So here's a riddle. What word in the English language, does the following? The first 2 letters signify a male. The first 3 letters signify a female. The first 4 letters signify a great, while the entire word signifies a great woman. What is the word? And you can type it into the chat. We'll be monitoring the chat to see if people actually guess this. And it's okay if you don't guess it. I couldn't guess it myself. I had to, oh, look at you, Ashley. Where's Ashley? All right, well, Ashley gave it away. So you're right, it is heroine. Obviously the he, the her, the hero, and then the heroine. I think as we look at all the things that have been going on over the last 1.5 years, we look at our frontline workers, And we look at all of the hard work that they've done. They are heroes and heroines, and we must applaud them in these efforts. Vanessa already mentioned that CCCU is a proud sponsor of this event, but however, Mr. Fraley was unable to make it this evening, and we're going to move on from there. So tonight, our objectives are to gain a better understanding of the benefits of diversity and inclusion among health professions, have an increased awareness of health outcome disparity data, learn actionable ways to increase diversity and inclusion in the health professions. And just so we're just kind of setting the stage for the discussion and make sure that we're all on the same accord in reference to terminology and our basic understanding of the most commonly used words in the DE&I space. So diversity is the practice of quality of including or involving people from a range of different backgrounds. Inclusion, often wondered, is it different? Do you believe it is different? And if you do believe it is different, or if you believe it's the same, please just kind of put it in the chat. What makes it different? What makes it the same in your vision of inclusion? Bias, having a prejudice in favor of or against one thing, person, or group compared with another, usually in a way that is considered to be unfair. Cultural humility. I know a lot of you might have heard of the term cultural competence. We've taken that to the next level, and the term cultural humility takes the pressure off the individual to the person that might be minoritized to have to explain their culture. This puts the power back with that individual, and it shifts it to the person, the practitioner, as opposed to the client. So whereas you might ask a specific question of someone to help you gain a better understanding, rather than having them give that answer, you approach it in a different manner, right? And it's about the intersectionality of all the identities that people have and shifting that power dynamic that often exists when we are wanting to know about another person's culture or how they identify. Then we have equality, equity, and justice. A lot of people use these words interchangeably, in particular, equality and equity, right? The assumption that everyone benefits from the same supports. This is equal treatment. However, it also alludes to there being a biological difference in individuals and understanding why they cannot they don't have the same experience as everyone else. Equity is looking at everyone getting the support that they need at the level that they need it, right? A lot of times people might associate affirmative action with this, and that is giving equity. However, justice is when you remove that actual barrier, whatever it is blocking the individual from being able to achieve what it is that they need to achieve. That systemic barrier is gone, and everyone can see at the level that they are, and there's nothing that is blocking them. And so we've moved this pendulum from looking at equality to equity into now justice, to understand that there are other things in place that often prevent us from achieving equality and equity in society today. I have some authors that actually took it to the next level, and they said not only are there barriers, there are actual deterrents to allowing folks to actually achieve equality, equity, and justice. There are physical restraints that are keeping people from actually achieving health, equity, societal equity, and is actually keeping them down, right? So portrayed are three people of equal stature experiencing external forces that distort how tall they appear to be. It reveals the biased foundational beliefs about innate differences in a value or merit that often undermine the success of equity-based interventions. So there are many dimensions of diversity. By no means is this list all encompassing. Take a look at it, and you might see something that, or you might not see something that you think should be there. Everyone brings something different to the table. I can look at a class of 120 medical students and know that every single one of them is bringing an element or a dimension of diversity to the table. And understand how we can be multidimensional. We don't always fit into one category. And we have to always think about how these dimensions intersect. And how they intersect is bringing those dimensions together so that we are a complete individual. How you define yourself may change based upon the room that you enter. So for example, if I go to my son's school, I'm entering as a parent, as a mother, as a concerned individual in reference to the educational system that my son is engaged in, right? I can bring in so many different dimensions of my diversity. I haven't even mentioned race. I didn't think about, where I stand educationally. So we have all of these different dimensions that we bring to the table that sometimes, a lot of times people see us as these one-dimensional individuals, when in actuality, we are multidimensional. We intersect throughout these dimensions and we're fluid in them. And we go in and out, just literally depending upon a situation or a space that we happen to enter. Are there any questions? I feel like I'm moving fast. I see Ashley, inclusion is honoring the perspectives of a diverse group. Having a diverse group isn't enough if people aren't heard. That is very true, Ashley. The other thing is about inclusion. So oftentimes there's diversity. You might have diversity across the board. However, it is exactly what Ashley is saying, having a seat at the table. If your leadership does not have diversity, it is not inclusive. Diversity and inclusion are two separate entities. You can be diverse and not inclusive. If all the power players look the same, come from the same background, and there are no difference of ideas coming in from people's different dimensions of diversity, you're not being inclusive. So we're going to start moving into some of the issues specific to Nevada and looking at some of the healthcare facts and issues that are going on here. So Nevada ranks 45th overall in physician and patient ratio and 48th overall in nursing to patient ratio. There are some counties that have no licensed healthcare providers in the more rural areas in what is called the frontier. So imagine having to drive 3 hours to your primary care physician or to visit a nurse practitioner. There are folks out there in the counties that do have to deal with that. Nevada and Utah had the lowest number of general surgeons per 100,000 population, 5.6 and 5.8 respectively. So if you needed surgery, good luck finding a surgeon here in Nevada. Nevada ranks 48th for the number of primary care physicians. And why is it important that we have primary care physicians? Because those are our first line of defense. We want people to go to their primary care physicians for preventative health care, as opposed to an emergency room where they're receiving tertiary care. We want someone that's going to be able to coordinate our health care as individuals so that this one person knows all that's going on with us and coordinates between our other healthcare providers if we have underlying health issues. Across the nation, there is an aging physician population. 30% of all licensed physicians are 60 plus, and we rank 38th in the nation. Nothing against having an aging physician population. However, they are going to be retiring, right? And so they have to be replaced. And so we have to make sure that in the pipeline, we have folks that are coming through that can replace those aging physicians that are about to retire. So the importance of diversity, why do we even need it? So back in 2004, the Institutes of Medicine made recommendations. In 2004, we are almost 20 years from that report coming out, right? Where they stated that diverse healthcare providers are more likely to serve in medically underserved communities. That patient choice of a concordant health provider leads to greater satisfaction and in some cases greater health outcomes. And overall, the quality of training is improved for all, right? So we have seen these reports and they have been, it has been researched. There's been tons of data that has come out in support of what the IOM originally said in 2004. However, as witnessed over the past year and a half, we've seen a lot of these recommendations have not been held to fruition. It's even more important now that physicians and dentists from underrepresented minority groups are present in the healthcare field, okay? And we wanna make sure that they are represented not just in the student body of medical schools or health professional schools, but also in the faculty and the staff of those health professional schools, right? So research has shown in this day and time, it is still the same data that physicians and dentists from underrepresented groups are more likely to practice in high need special areas that are typically medically underserved. Student body diversity is associated with better overall student preparation to care for these minority population. And it's an endorsement of equitable access to care. When a patient walks into a room and sees a healthcare provider that is speaking their language or might look like them or came from the same community from which they've come, there is a level of comfort that those patients may feel, thus greater satisfaction and better health outcomes. A diverse workforce may improve healthcare professionals' cultural competence and better prepare them to respond to the needs of the entire population. So data from 2019, the Integrated Post-Secondary Educational Data System. So as many of you know, Roseman has multiple health professional schools, pharmacy, dental medicine, nursing, and it's soon to be medicine. And as we look at these numbers and we see that based upon 2019, so if we look at 2019, the tail end of 2019, no one knew what was coming in the year 2020. No one knew COVID was there. And then bam, here we are in 2020, and the nation is on lockdown. Healthcare providers are overwhelmed in emergency rooms, in all kinds of hospital settings with patients coming through the doors, okay? And we're looking at the demographics of those individuals that are tending to the patients that are walking through the door. The patients that are walking through the door were from minoritized communities. They were Black, they were Hispanic, they were Native American at a higher rate than any other groups that were coming through the door. But they were met with a health professional workforce that did not resemble them, right? And so if you're looking at the numbers here and you see nurse practitioners were at 63%, 64%, of them were white, about 14% of them were Black, less than 0.5% of them were Asian American, Asian American Indian, Native American, and 11.4% were Hispanic. Those were the frontline folks. The nurses were the first ones to meet them. Then came the physicians, who were 60%, overwhelmingly 60% white, 5.8% were Black, 0.4% Native American, and about 8.5% were Hispanic. So those numbers in particular related to medicine have not moved. in the last 20 years, they have kind of hovered around the same place for those groups that are considered underrepresented based upon how they represent in the national public. And so we're looking at this almost, it's not a mirror of the United States. It's a close up on what is happening with the United States educational system when it comes to preparing students for a health professional career, and how options are available for some while options are not available for others. And we will talk more about how we can kind of fix some of the issues that are going on with these disparate numbers of representation in the health profession field. We're going to hone in a little bit more on medicine, right? We're going to look at data from the AAMC, the American Association of Medical Colleges, and look at how data has changed over the years. And looking at women, 50% of the population, are only 36% of the US physician population. Racial and ethnic diversity, which I kind of mentioned in the last slide, 14% are represented in that number. And in 2014, there were actually less Black men in medical school than in 1978. The overwhelming majority of medical students come from an upper middle class upbringing, right? 5% of the students that are coming into medical school right now are from the lowest household income quintile, meaning first generation students, students from those underrepresented and under-resourced communities are not walking through the doors to receive any kind of education related to medicine. And so there's an issue there when the folks that we are treating are not able to access an opportunity to actually make a difference in their own community. Recognizing that it's not a straight path for many to get into medical school, we have to talk about how we address these disparate numbers for women, men, Black men in particular, and students coming from low socioeconomic status. Minority health determines the health of the nation. You're only as healthy as your sickest person, right? It is predicted that by 2050, 49% of the US population will be non-Hispanic whites. 51% will be comprised of all other racial and ethnic groups. A shift in the majority population warrants a shift in how healthcare is delivered. As a nation, we have been discussing about health outcomes and ongoing health disparities for well over 20 years. I remember being in school and they were talking about healthy people 2000 and healthy people 2010. Well, here we are and they're talking about healthy people 2030. And we have not seen any significant change in these health disparities. In some cases, they've gotten worse for some of these populations, but they keep presenting us with the same interventions. Something is broken in the system, and we have to figure out how to fix that. Health disparities are preventable differences in the burden of disease, injury, violence, or in opportunities to achieve optimal health experienced by socially disadvantaged, racial, ethnic, and other population groups and communities. Health disparities exist in all age groups, including older adults. So we're going to talk about some of these and kind of go into a little bit more detail about what some of these disparities actually are and that they've existed for all these years. So if you're not familiar with the most recent COVID data that has come out, this year it's revealed that BIPOC, which is Black, Indigenous, people of color in the US, have been 3 times more likely to contract COVID-19 than white residents and nearly twice as likely to die from it. And the question is always why? If everyone is doing the same thing, if they are masking up, if they are social distancing, if they are washing their hands, if they are getting vaccinated, should these numbers be going down? Shouldn't they? There's a question as to why they aren't going down if everyone is behaving in the same manner, right? And it kind of goes back to that picture that we saw of the individuals at the fence and understanding everyone got the same treatment. Why are the numbers so different? Why is it that some groups are contracting and dying from COVID at higher rates than others? There has to be something else in play. And we're going to talk about some of these things. So we're going to talk about each group individually, just so we get acclimated to what we're about to go into. African Americans, as compared to their white counterparts, are generally at higher risk for a number of chronic diseases, cancer, cancer, stroke, asthma, pneumonia, diabetes, HIV/AIDS, right? So as you've known from the news, anyone with an underlying issue, health issue, is at even greater risk, right? So they may be vaccinated, they may be social distancing, wearing a mask, washing their hands, but these extra underlying issues that they have are exacerbating COVID. There are other factors involved with this as well, right? So where are people living? How are they living? These are questions that all have to be asked. And we'll talk about that in a little bit. Asian Americans are most at risk for cancer, heart disease, diabetes, and conditions including hepatitis B and liver disease. This demographic is not a monolith, and there are subgroups that experience greater disparities than others within the Asian American population. And we have to keep all of these in mind when we're working with these different populations. No group is a monolith. They all have varying degrees of ethnicities, multiracial. So there's so many, once again, these dimensions of diversity matter when you're assessing the health of your patients, and they have to be taken into consideration outside of the fact that, you know, they are at this high risk level. American Indians and Native Alaskans, they have some of the highest rates of liver disease, malignant neoplasm, unintentional injuries, diabetes, and they have one of the lowest life expectancies in the United States of all races at 73 years of age. So here's our paradox, the paradox of health. Despite lower income and less access to care, Hispanics are less likely to die from many of the leading causes of death. They do have higher prevalence of some chronic disease, such as diabetes and kidney disease. Does anyone know what this might be about? Why this paradox exists in this group? Why would they be less likely to die? Well, I'll answer that for you. A lot of times, data has shown that it is often the social networks that they have created. If they've immigrated here, they are a very socially close-knit group, and they rely on each other heavily, and that social component is sometimes the edge in helping them live a little bit longer. They are resilient when they are working in or thriving in their within their own social circles, and they support each other wholly. And you might say, well, other groups do that too. To some extent, they all do. However, there's something going on here with this population that does need to be examined to understand how are they able to overcome some of these disparities and live and not die, as so many other groups are from these chronic illnesses. So we move from talking about the disease and talking about illness and looking at as if it is what defines an individual. And when a person walks through the door, and if we are healthcare providers, we see a disease, right? Oftentimes we don't see the person that's coming through the door, and we don't understand their lived experience in many cases, right? So a person, I remember going to the doctor, and I take a history. I take a history the first time I go see that doctor for my physical exam. Oftentimes I'm not asked to do another history. No one is asking me some of those repetitive questions. They don't go back and ask me, are you still employed at this place? Or, you know, has your marital status changed? Most likely the question I get asked most often every year when I revisit is, do I still have the same health insurance? That's the question they want to know. They want to know, are they going to get paid if they see me? So if anything else in my life has changed, a lot of times they're not aware. I have to disclose that information. These factors tend to be kind of discounted. No one's really thinking of them when we're talking about providing healthcare. The social determinants of health are the conditions in which people live, born, learn, work, play, worship, grow old. They live in most places that some people could not live in, right? So there are some people that could go through to an area and say, how can someone live like this? They don't have any grocery stores. They don't have any parks. And if that is all they have available to them, how is their existence supposed to help them thrive? How are they going to thrive in an environment that is not conducive to living? So just out of curiosity, if you know anything about the social determinants of health, what do you consider to be the most important issue that should be addressed when a person walks into the doctor's office? You can throw it in the chat. And I'm going through the chat right now. Yes, someone has said the electronic health record systems are not good for capturing social determinants of health. That is absolutely true. A lot of times they literally are very disease-based, and they don't offer you the opportunity to ask some of these pertinent questions that can get at the root of what is actually going on. Someone entered family and social support network seems to be important to them in addressing the social determinants of health. I think that's a really good one. I think that one kind of supports the Hispanic population and how they are able to outlive other groups with these different chronic ailments that they have. And I think it also leads to a level of resilience that they have because of those family and social support networks that they have in place. Anyone else have anything else that they want to add to that? Trust. Do I trust my healthcare provider? Trust is major. Trust is what we're not seeing these days when we have a lot of vaccine hesitancy. Historically, contextually, the level of trust between minoritized communities and the healthcare system has been very low. And if going through the door, there is limited or low levels of trust, many of the questions that you may ask won't get answered, or you might think that they are, in some cases, and the data has shown this, that physicians think some patients are uncooperative or don't want to adhere to a treatment plan, and they're difficult patients, when in reality, it could be they couldn't afford to pay for their medication. They had to pay a light bill. They had to pay for transportation. they missed a day of work because they were trying to get to the doctor, whatever that reason may be. The question to ask that person is, what is going on with them that is preventing them from adhering to whatever treatment plan is suggested or given to them from their healthcare provider. It's not moving. There it goes. No, it didn't move. Sorry, Mike. Oh, there it goes. So here are examples of conditions that can prevent individuals and communities from thriving and not just surviving. People want to thrive and not just survive. Surviving is the day-to-day that people go through just to get to the end of the day and go to bed and wake up and do it all over again. It's almost like the hamster in the wheel. You're just spinning in a wheel to just survive, right? People should be able to thrive and not just survive. I consider these to be basic needs that everyone should have or have access to in society. For many BIPOC communities, over half of these conditions are non-existent and they prevent them from thriving. So affordable housing should be something that is available for everyone. Quality education, a healthy built environment. So having access to parks, having access to sidewalks. There are so many communities that don't have sidewalks, that don't have adequate lighting. And if you're a senior citizen and the doctor has told you, oh, you should get out and walk for 30 minutes a day. That is the health, suggestion for everyone. You should get out and walk 30 minutes a day. If you don't have sidewalks, if you don't have lighting, adequate lighting, are you going to really walk in your neighborhood? So all of these things impact health outcomes. And what we're seeing is that these social determinants of health are actually really the root cause of the issue that is going on with the patient, right? My boss has said it is your zip code that determines your health, right? Where you live can determine whether you thrive or you survive, right? So how do we address the issue? So we're going to look at it systemically, and we're going to look at it from an educational perspective. So systemically, we need to identify and oppose racism at the individual, institutional, and policy level. One of the things that is suggested from a lot of research, universal healthcare. Healthcare should not be a privilege. It should be a right. Everyone should be entitled to adequate and accessible healthcare, right? With a distributive justice model, which means those that are most in need should have greater access to better healthcare. Racial identifiers should only be used if they promote a probing examination of the racism negatively attacking their well-being. Race is a made-up social construct, right? And in a lot of situations, when you walk into a healthcare provider, you are looked at in a very, you are a Black woman. So therefore, you are associated with all of these different chronic diseases. When in actuality, they might not know what my background is. I could be the healthiest person walking into the room, right? So take race away and just look at me as a woman of a certain age walking into the room, and you're asking me questions, not based upon your assumptions about my race and what my behavior might be or what my living condition might be. Hospital and healthcare institutions have to be more involved in the human capital and the economic development in local communities. So when we look at a lot of major healthcare systems in the country, they are situated in urban areas, typically within communities of color. And there's almost an invisible wall. Sometimes it is a very visible wall that disconnects that hospital or that healthcare institution from the rest of the community. And so we want to make sure that we tear down those visible and invisible barriers and be able to connect with the community and build that trust, right? If trust is a social determinant of health, how do we build that trust back in with the community? We break down those visible and invisible barriers that are present. Acknowledge the structural cause of risk and vulnerability must be addressed. Vulnerability describes a set of conditions of people that derive from the historical and prevailing cultural, social, environmental, political, and economic context. For example, generational wealth. There are some groups that have long histories of generational wealth in this country. One of the reasons some groups do not have generational wealth is because when they came back from World War I, World War II, they were not provided FHA loans. They could not get a home, they could not buy a home, and data has shown that home ownership is the beginning of creating generational wealth. If you can't own a home, or you could not purchase a home in the 40s, 30s, whenever they were giving out FHA loans, you were unable to move into certain areas. You were not able to have affordable housing, safe housing. Oftentimes you're living in overcrowded conditions. And so you're kind of living literally in the realm of social determinants of health. So how do you get out of that? The systemic issues that exist must be addressed. So the AMA has decided this year that systemic racism in medicine is the most serious barrier to the advancement of health equity and appropriate medical care. They came up with a system, some policies that they believe can help address some of the systemic issues, and they are implementing them, and they expect healthcare providers and healthcare institutions to live by some of these policies. Clearly defining discrimination, systemic racism, explicit and implicit bias, and microaggressions in the healthcare setting. Call a thing a thing. You must identify it, name it, claim it, and fix it. And that's how we move forward. But if you don't own up to it, it can never be addressed and it can never be fixed. Ensure that policies are prominently displayed and easily accessible. Out in front. Don't let anyone have to guess what your institution is doing to address the systemic issues that have plagued the healthcare system for decades. Describe the management's commitment. Management must be committed to providing a safe and healthy environment. If the higher ups in the organization don't buy into this idea that systemic racism exists, then we will not see people below them behave in a manner that prevents the continuation of the systemic racism. And so everyone at every level has to acknowledge what's going on. Management has to be committed to ensuring that their environment is the best that it can be for everyone and not for a few. Training requirements that address racism, explicit and implicit bias, and microaggressions. And it's not enough to say, oh, we're going to close down for the day and we're going to do a diversity training, right? This is great what I am doing. And I love what I do, but I've always said, I will never be out of a job, because until the systemic issues are actually addressed adequately, there is always going to be a need to talk about diversity, inclusion, and all of these other issues associated with diversity and inclusion. I would love to be out of a job doing this. This is one of the hardest jobs, to get people to understand that I can talk about it, but if the systems don't change, nothing will change. The other issue is when people report, there has to be a way where you report and you feel safe and you don't feel like there will be any backlash. and you won't have retaliation. So there has to be a safe reporting mechanism in place to actually capture these issues and document them. You should be able to look at a report on a monthly basis of incidents that are happening in the workplace, whether it be discrimination, bias, harassment, all of those things should be able to be captured and documented so that at the end of the month, you can get a report to say, oh, we've seen a change. We're seeing less reporting of these kinds of incidents, right? And begin to believe that whatever systems that you have put in place is addressing and correcting any maladaptive behavior. So how do we address it educationally? Health professional education institutions bear the responsibility for healthcare workforce production. That's us, right? So here are a few things that we can do as a health professional educational institution. Increase pre-health programming and pathway accessibility. How do students that are considered or have been traditionally underrepresented in health professional schools gain access to the resources that they need to, one, be educationally prepared to enter into these very competitive programs, right? We have to create programming and pathways accessibility has to increase for these groups of students. The diversity of the HPIs must be increased at the faculty level and the staff level, as well as at the leadership level, right? So when you look at students, I will only speak from my experience. In working at my previous institution, one of the things students would always tell me is that they would go to the website and see who was running things, who's in charge, who are the people that they put on the website, what does it look like on the website? Is it a diverse group of people? And do I feel like there's a sense of community that I can build or is already established and I can fit into readily, right? So having a sense of community is important to a lot of students when they walk into the building, but it's also that way for faculty and staff. And so in order to increase that diversity of students, you have to increase the diversity of your faculty and staff who's going to be teaching this diverse group of students. Once again, creating meaningful relationships with the surrounding communities. There are a lot of schools, medical schools, that are associated and affiliated with some of these academic health centers. But then there are some that are freestanding medical schools, and they are right in the heart of some of these urban areas. And there is a lack of trust pertaining to these institutions and the community. And so oftentimes the history of these institutions going to these communities, collecting data, and not giving back to the community, right? So a $25 gift card to Target is great. However, it does not improve my health outcomes. It will not help me move from my maybe, leaking pipe apartment into a better, more affordable housing. So, well-meaning though it may be, it does nothing for the community as a whole. So how do we uplift? How do we support a community? How do we help a community develop? We create these meaningful relationships with them. And we say, we're gonna partner with you. If I write a grant, do you have any community-based organizations that we can put on a grant and we can both be PIs? We could be co-PIs on the grant. That is providing resources to the community in a different way, in a more meaningful and long-lasting way. One, because you're building up a community-based organization and its infrastructure, which is also allowing it to have the ability to provide more services to the people within that community. So it can't be surface level relationships that we're building with the community. They have to be able to sustain themselves over time if we're going to see any kind of improvements within these communities. Incorporate anti-racism lectures and historical context in the curricula of medical schools. So my students have often told me that case studies are racist and they are very matter of fact about it. And, you know, diabetes and Black people always seem to go together in the lectures for them, or diabetes and Native Americans and alcoholism. So it's the race associated with the disease. Once again, race is a made-up social construct. And we don't need those in order to understand the context of disease. So as we start to educate, we need to understand the historical context of what has gone on in medicine and why people have developed a mistrust of the healthcare system and going in and seeking the assistance that they need. So discontinuing the use of biological race in health professions, it's unchallenged, it's outdated, and it is rampant throughout clinical education, research, and practice. That is, you know, at the core, I believe, of a lot of things that could change the face of medicine, could change how the health professions are trained if we don't look at race as a biological construct and as a social construct. So I have a shameless plug. So what are we doing here at Roseman? Well, we understand the community of Southern Nevada. We've been here for 20 plus years. We understand the diversity of Southern Nevada. We understand the need to increase the numbers of healthcare professionals in Southern Nevada. So we have created programming that we believe will address some of the issues in reference to the lack of diversity or the lack of the ability to increase what I want to say is community wealth, not generational wealth, but community wealth, and allow our students that are coming from Southern Nevada the opportunity to have experiences, access to resources, and also feel like they are a part of a community. So Aspire is out of the College of Medicine, and it is run through my office, the Office of Diversity, Equity, and Inclusion. And it's a multi-level medical school pathway effort that is, the sole purpose is increasing the number of qualified students who have been traditionally underrepresented in medicine. A lot of them are going to be coming from educationally or economically disadvantaged communities. I want the kids that don't even have medicine on their radar. Those are the kids that I am going after, right? And so we want to make sure that they have opportunities, that they have the resources given to them so that they can pursue a career in medicine. And then we have Spark, which is a Roseman University-wide interprofessional pathway program. And it looks to be really for sparking that interest and passion in high school students and prepare them for a career in any one of the health professional schools here at Roseman University. So as we, grow and continue to be a part of this community, look for these programs to make an impact on the community in Southern Nevada. I've learned that people will forget what you said, they will forget what you did, but they will never forget how you made them feel. And that is what we want to do. We want to make sure that everyone knows how Roseman is different. We want to make sure that they feel good when they interact with us, whether it be in our educational system, in our pipeline programs, as faculty, as staff. We want to know that we made them feel good. Any questions, comments, or concerns? This is a quiet group. Well, Vanessa, I'm going to turn it back over to you. There's no questions. I didn't see any in the chat.
Thank you, Zan, for your comment about this being a great presentation. We agree. Thank you so much, Dr. Brewster. We're all incredibly proud of the work that you're doing and the work that the College of Medicine is doing.
Oh, I saw Zan. Wait, Zan did ask a question. How does Roseman plan to reach out to high school students? So we can both answer that question. So one of the ways that we are doing it at the College of Medicine, we are actually going through our community-based organization partnerships that are youth serving organizations. And so through them, the College of Medicine is creating programs attached to those organizations. So we have a high school program that we'll be kicking off with 2 of our community partners, one on the east side, one on the west side. And those will be starting in October. So we won't necessarily be working with a particular school, but the organizations serve multiple schools. So we'll have a mix of students from various schools on the east and west side of Las Vegas. And Vanessa, do you want to talk about Spark?
Sure. Spark is working through CCSD with all of the available high schools that are interested in becoming partners this year. And in this first year, we're starting off with about 8 high schools across the valley. Some have specific health sciences tracks and some do not. So it's a diverse collection of high schools. So we'll be working with them as well as working at the undergraduate level to form relationships with higher education institutions, as well as some of those pre-professional students as well.
Dr. Kaufman has asked me to talk about our Diversity Inclusion Advisory Council, which was formed last year. We got approval this year. Thank you, Dr. Kaufman. And one of the things, one of the reasons why we started this, it was kind of an offshoot from all of the issues that were happening last year during COVID, the death of George Floyd and Breonna Taylor. These were all incidents that kind of ignited a lot of what is going on now in society. And so I arrived in June of 2020, and my prior institution, I had a committee, and we did a forum around the incident with George Floyd. And one of the things I thought of was we should create a university-wide committee that kind of looks at some of these issues that are coming up. And so we, got representation from each unit and college to sit on this committee. They were appointed, and we have been creating and developing programming. We actually have created a diversity survey that we will be implementing hopefully this fall to kind of get at some of the issues that we think might be present. We don't know if they are, but we've heard things from students, some staff. So we just want to make sure that we are that welcoming environment for everyone. And so we are doing that. We are having a Taste of the World event that we're going to kick off in the new year, where everyone brings a dish from their ethnic or racial background, and we celebrate being diverse in all the dimensions of our diversity. We will be doing a town hall to reintroduce ourselves and all the people that have been actively engaged on the DIAC. And we are looking for folks to be on the DIAC. So if anyone is on this call that is Roseman employee, or even if you're not a Roseman employee, we do have alumni that sit on the DIAC. So if you are in any way affiliated with Roseman, we welcome you to sit on this committee. We are not a governing body. We create programming, we advise, and that's the position that we play here at Roseman University, which it's a great position to be in because we can kind of take information and compile it and take it to the admin council or the executive council, so that change can actually occur. So we're happy. Will Aspire be a part of the Utah campus? So we are working on that. One of the things that one of my colleagues, Shayla, is working on is getting us into Utah. We do have interest in, I've met with the chancellor at Utah, and we have another colleague of mine that is in Utah, and she's interested in actually having some activities take place up there. So not this year, but once we get rolling and we get more boots on the ground, that is definitely in the works to have Aspire, and I would believe Spark up in Utah. We just got to get boots on the ground, got to get folks up and running. Have you all thought about having a human library program as part of the DIAC programming as a way to promote learning about diverse groups? Dan, please talk to me about a human library program a little bit, if you could.
Okay, I'm gonna unmute myself. Can you hear me?
Yes.
Okay, so human library programs are programs that bring people together, and the people are books, and folks get to check these books out, and then you get to learn about someone's experience. So the Las Vegas Clark County Library had such a program, and it was community-wide, but it might be something you could think about to spark learning for folks.
Okay, I will look into it for sure. One of the things that the library did do, I sent them a list of resources and books that if they did not have, they should have as a resource, or allow students and faculty to have access to some of those resources. So they have been actually very positive in working with us. And so, yeah, I will definitely look into the human library program. Thank you. Given the events of the past 5 years, what can be done to make political party affiliations benefit from principles of DEI? Oh, that's a really tough question, Dr. Brewster. I think one of the things is really education. And I think it has to come from a grassroots perspective. I think politics for a long time has been dominated by a small group of people, right? And as we start to spread out and we start to see folks that don't have these long history of being in politics, and we see grassroots folks getting into office and sparking some of these changes, I think that's how you change, or you begin to see political parties build and develop some of these principles of DEI within their ranks. I think right now, that is probably the only way we're going to see any political party affiliations benefit from DEI. There has to be a shift, a dynamic shift in the face of politics, literally and figuratively, for us to see those changes. We have to see people from, different backgrounds. It takes a lot of money to get into politics and to run for political office in many cases. And that oftentimes leaves out a large population of individuals that might have the ability, or they might have the desire to be in a political office, but they can't afford to be in a political office. So there has to be some leveling of that playing field in order to begin to see a more diverse populace of folks running for office. Any more questions? All right. Take it away, Vanessa. I want to thank you all for being here tonight. I truly appreciate your time. I know it's after work hours. So I do appreciate people signing on and sticking through with us. And I do hope you got some good information that you can use. And if you have any additional questions, I'm happy to answer anything offline. And you can always find me on, via email.
Yes, thank you everyone for joining, and thank you, Dr. Brewster, for an incredible presentation. And we hope everyone stays well and safe. Good night.